So with that, I would like to introduce our first speakers, Juliana Rivas, HAI Prevention and Response Program Manager, and Celine Sanchez, HAI Epidemiologist from the ADHS Office of Health and Infections. They will be talking about the tracking and tackling multidrug-resistant organisms, a statewide initiative. Juliana, Celine, the floor is yours now.
Awesome. Well, hello, everyone. My name is Celine Sanchez. Like Rashana had just mentioned, and me and Juliana will be presenting today. So next, we're gonna go over the objectives. So the objectives today are tracking the data and tackling the data. So in tracking the data, we're going to be talking about carbapenem-resistant Enterobacter or CRE, and carbapenem-resistant Encinobacter baumannii, carbapenem-resistant Pseudomonas aeruginosa, and Candida auris. And then next, in tackling the data, we'll be talking about Arizona's response tiers, key prevention strategies, reporting rule updates, interfacility transfer notifications, and then lastly, we'll give you guys some resources and relevant publications. So let's go into tracking the data. So like I said, we'll first talk about CRE. So some background on CRE. CRE are organisms in the Enterobacterialis order that are resistant to one or more carbapenem antibiotics and therefore can be really difficult to treat. Carbapenem antibiotics include ertapenem, imipenem, and meropenem. They're listed right here. CRE can cause various illnesses, including meningitis, pneumonia, sepsis, diarrhea, and UTIs. Most of the cases that are reported to us are collected from urine. We do see high mortality in patients with bloodstream infections also. In recent years, majority of CRE cases reported to Arizona are resistant by a particular mechanism known as carbapenemase production. And that's what this graphic is right here. So carbapenemase production is where the organism produces the enzyme carbapenemase, and that neutralizes the carbapenem antibiotic. So it's kind of what this is showing here, that being neutralized. So when we're talking about carbapenemase producing genes of interest, what we focus on is KPC, NDM, VIM, OXA48, and IMP. And we mostly see KPC and NDM here in Arizona. And also, this type of resistance is easily spread to other organisms. So just to note, all of this data, this is 2025 data, and it is preliminary and subject to change. So here we're going to show you some year-to-date stats. So this will be from January to October 2025. So to October 2025, our current case count was 1,750. And we have those kind of separated into two groups here. So those groups are infection and screening. And what we mean by that is infection cases, those samples were collected for the purpose of diagnosing or treating disease in the course of normal care. And then when it comes to screening, those samples were collected for detection of colonization. So that's what we mean by infection and screening. And so for infection cases, we had 1,440. And for screening, we had 278. And out of that total case count, 1,270 were carbapenemase producing. And our 5-year average is 828 cases. So here's a little breakdown of our resistance mechanisms year to date. Again, 2025 data, preliminary to change, or preliminary and subject to change, sorry. So I'll go through the resistant mechanisms. So like I mentioned, MDM is the largest group that we see with 1,144 NDM cases. Following after that is KPC, 182 KPC cases. And then we go into the other resistant mechanisms. So we have VIM at 19 cases, OX at 19, and then IMP is 0. So I know there's been a shift over the years with KPC and NDM. So previously, we'll show you another graph here in a little bit, but previously we used to see more KPC than NDM, but now there's been a pretty big shift into NDM, as you can see here. So these two graphs we can see, we're going to go over CRE over the years. So the graph on the left shows the unfortunate but significant increase in CRE cases over the years. And it's been a continuous increase since 2018. And you could see here this pretty big jump from 2023 to 2024. So confirmed and probable CRE cases have increased by 55.5% between 2023 and 2024. And this graph on the right is showing the percentage of carbapenemase producing CRE. And this has the percentage of carbonase producing CRE cases by year, with a 3% increase from 2023 to 2024, which isn't a large increase when you consider the number. But if you look at that steady increase in carbapenemase production, it's pretty significant, but it makes sense because the number of cases are increasing. So as it would, the number of carbapenemase producing CRE cases would increase as well. But yeah, I mean, 87 is getting pretty close up there. So we just continue to see a rise in these cases. Okay. So this was kind of what I was talking about with the resistant mechanisms over the years. So you can kind of see that KPC is this purple. So in the beginning, KPC was the highest that we saw, or the most we saw for resistant mechanisms. And then over the years, it's kind of striking to see this graphic and see the intense increase in NDM, from especially that jump from 2021 to 2024. That went from 2021, there was 164 NDM cases, and then in 2024, there was 1,179 cases. So that is a really big jump. And also, it's just important to note that cases can be counted in multiple categories. So, for example, a single isolate could carry both NDM and KPC. And then, yeah, this just has the resistant mechanisms listed out. But yeah. Okay, now we're going to move on to crab. So crab is a gram-negative bacteria, Acetobacter baumannii, that is resistant to one or more carbapenem antibiotics, and these include imipenem and meropenem. We have them listed right here. They can be resistant by a particular mechanism known as carbapenemase production, which we just talked about that with CRE. But what happens here, the organism produces the enzyme carbapenemase, which then neutralizes the carbapenem antibiotic. So the same mechanism as CRE. So crab is commonly associated with healthcare-associated infections, particularly in patients with prolonged hospital stays, ventilator use, and invasive devices. Crab can cause a variety of serious serious infections, including pneumonia, especially ventilator-associated pneumonia, sepsis, meningitis, wound infections, and urinary tract infections. Crab is an environmental hardy organism and can survive for long periods on surfaces and equipments, leading to outbreaks in healthcare settings. Resistance is often due to carbapenemase enzymes, most commonly oxotype beta lactamases. So, for example, we have OXA23, OXA51, OXA235, OXA143. Those are just some examples of what we see. And some of those, like the resistant mechanisms of interest that we see most commonly, are listed right here. So that's OXA23, OXA51, and then OXA235. Other less common carbapenemase genes include NDM, KPC, IMP, and OXA48, but we have not seen these in Arizona for crab. Additionally, high mortality rates are associated with bloodstream infections and pneumonia, particularly in critically ill patients. Crab is a major pathogen known for antimicrobial resistance. So here is some year-to-date stats. So again, this is 2025 data and that it's preliminary and it's subject to change. So just keep that in mind. And this is also up to October 2025. So our total case counts for crab is 189 cases. And for infection cases, it's 177. And again, just a reminder that infection cases, those samples were collected for the purpose of diagnosing or treating disease in the course of normal care. And then screening samples were collected for detection of colonization. And out of those 189 crab cases, we saw 172 of those were carbapenemase producing. Another thing to note is this year we expanded our reporting rules for crab and CRPA, which will likely impact the 2025 data. But Juliana will be going into that later in more detail later in the presentation. So for the resistance mechanism breakdown, we see OXA23 as the highest here with 153 cases. And then we see OXA51 with 16, and then OXA235 with 3 cases. So on this slide, we're comparing crab from 2023 to 2024. So in 2023, we had a total of 47 cases. And in 2024, we had a total of 261 cases. So pretty large increase, as you can see, just by the numbers alone. So then going into the resistant mechanisms and the breakdown for each year, in 2023, OXA 23, we had 43 cases, 0 OXA 51, 4 OXA 235, and then 2 pan-R/pan non-susceptible. And then comparing that to 2024, we had 248 OXA 23 cases. For OXA 51, we had 11. OXA 235, we had 1. And then for pan-R/pan non-susceptible, we had 15. So just some notes that are here on the bottom is that carbapenemase producing crab and resistant crab were reportable in 2023 and 2024. Reporting rules have since been expanded to include all crab as of June 2025. And again, just to note, cases can be counted in more than one category. For example, pan-R and OXA23. Pan-R is defined as resistant to all antimicrobials included in the susceptibility testing. And then pan-NS is defined as non-susceptible to all antimicrobials included in susceptibility testing. Okay, let's move on. We're going to go into CRPA. So CRPA is a gram-negative bacteria, Pseudomonas aeruginosa, that is resistant to one or more carbapenem antibiotics. So for CRPA, we have imipenem and meropenem. And again, they can be resistant by a mechanism known as carbapenemase production, in which the organism produces an enzyme carbapenemase that neutralizes the carbapenem antibiotics. So again, the same enzyme and the same mechanism that we see for the other MDROs that I just discussed. CRPA is an opportunistic pathogen and can cause infections in blood, lungs, pneumonia, urinary tract, or other parts of the body after surgery. Frequently associated with healthcare settings, particularly among patients with burns, cystic fibrosis, mechanical ventilation, or indwelling catheters. Carbapenemase resistant arises through the carbapenemase production, like I just mentioned. CRPA is capable of forming biofilms, contributing to persistent infections and resistance. And so some of these carbapenemase producing genes of interest, we have KPC, NDM, VIM, OXA48, and IMP. Also, CRPA is associated with high morbidity and mortality and is extensively drug resistant and can be. Okay, let's move on to year-to-date stats. Just to note that this is 2025 data, is preliminary and subject to change. And another thing to note, same note for CRAB, that this year we expanded our reporting rules, which will likely impact 2025 data. And again, Juliana will go into that later. So year to date, up from January to October 2025, our total case count is 68 cases, and we have 62 of those are infection and 5 are screening. Same definition for the previous MDROs I mentioned: infection collected for the purpose of diagnosing or treating, and the treating disease in the course of normal care; screening collected for detection of colonization. And then we go into the mechanism breakdown. So for IMP year to date, we've seen 14 cases. For VIM, we've seen 2. KPC, we've seen 3. And then MCIM plus PCR, we've seen 2. And this last bar right here, this is where the case shows they are carbapenemase producers via phenotypic testing, but additional testing was not done to show what producer it was. We only see this a few times, and usually just with CRPA. Okay. So here we'll compare CRPA 2023 and 2024. So in 2023, we saw 14 cases, and in 2024, we saw 32 cases. So that's a 128% increase when we're comparing from 2023 to 2024. And when we're going into the mechanisms, you can see here that we had 8 IMP cases for 2023 and then 15 IMP cases in 2024. And again, another significant increase is the VIM. So there was 0 VIM cases in 2023 compared to 6 VIM cases in 2024. Also, just some other important notes here. Carbapenemase producing CRPA and pan-resistant CRPA were reportable in 2023 and 2024. Reporting rules have since been expanded to include all CRPA as of 2025. Cases can be counted in more than one category, for example, PAN-R and IMP, and same definition as CRAB for PAN-R and PAN-NS. PAN-R is defined as resistant to all antimicrobials included in the susceptibility testing, and PAN-NS is defined as non-susceptible to all antimicrobials included in susceptibility testing. Okay, last but certainly not least, we have Candida auris, or C. auris. So Candida auris is an emerging fungus that can spread easily in healthcare settings and can cause severe multi-drug-resistant illnesses. Symptoms depend on the site of infection. Patients with C. auris bloodstream infections typically have sepsis and or severe illnesses. Other invasive infections such as intra-abdominal candidiasis and meningitis can also occur. C. auris has also been found to cause wound infections and otitis, and it has been cultured from urine or respiratory specimens. C. auris has been found to colonize on the skin of asymptomatic people. So here, year-to-date stats. This is 2025 data. It's preliminary and subject to change. So up until October, we've seen 409 CRS cases and pretty good split down the middle with 205 clinical and 200 screening. Now, these definitions are a little different than the other MDROs we talked about. So clinical is defined as person with confirmatory laboratory evidence from a clinical specimen collected for the purpose of diagnosing or treating disease in the normal course of care. And screening is defined as person with confirmatory laboratory evidence from a swab collected for the purpose of screening for CRS colonization, regardless of the site swabbed. So here we'll look at CRS over the years. So you can see the cases have arisen from 2022 to 2024. So in 2022, there was 53 clinical cases and 152 screening cases with a total of 205 total cases for 2022. And then moving to 2023, the number of clinical cases increased to 124, while screening cases decreased to 77. And then in 2024, there was a notable increase in both categories with 155 clinical cases and 216 screening cases, with a total case count of 371 for 2024. So that's a pretty big increase. 180% increase in 2024 among screening cases compared to 2023. And then there's a 25% increase in 2024 among clinical cases compared to 2023. So that's all I have for tracking the data. Now I'm going to pass it over to Juliana, who will talk about tackling the data. Thank you.
Thank you so much, Celine. Hi, everyone. As mentioned earlier, my name is Juliana Rivas. I'm the HAI Prevention and Response Program Manager. And so I just want to give a huge kudos and shout out to Celine. She did such a great job providing a summary of the data that we see here in Arizona for our targeted MDROs. And like she mentioned, I will be now talking about how we are tackling the data now that we've received that overview and background. We'll talk about how we tackle the cases, the outbreaks, and just essentially what we're seeing. Because if you're anything like me, hopefully the data she shared helped get your wheels turning a little bit. And the first question you probably asked was, what are we doing about this? And I will do my very best to answer that. And hopefully we will have time at the end for additional questions as well. Next slide, please. So first and foremost, it's important to note that CDC does provide two key strategies for management of the multi-drug-resistant organisms. The first is the prevention strategy, and that strategy aims to reduce the emergence and transmission of MDROs using proactive measures and having a specific prevention plan in place to target those MDROs. The second is the containment strategy, which is a much more immediate response strategy designed to stop or slow the spread of MDROs once they have already been detected. So the difference between these two is that prevention, it doesn't wait for a case or outbreak to be detected. We want to proactively use that approach to target all MDROs, whereas the containment strategy will wait for a case to be detected for us to then respond to. And so the additional differences between both documents is that the prevention strategy is a relatively newer document, and it launched in 2023 by CDC. And later on, we will talk about those strategies a little bit more in depth and what is involved within this prevention approach and the role that they each play. Now, the containment strategy has been a document that was developed early on. I want to say around 2019 was when it was initially released by the CDC. And the CDC did recently update the strategy and launched the updated version in 2023 as well. So here shortly, we will also discuss those key response elements. But before we do that, I also want to mention that both guidance documents are publicly available on CDC's website as a resource. I will say that resource and the documents themselves are aimed for state and local health departments. But that being said, I do think it's a really great resource for information for clinicians as well. And so I know we have several clinicians on the call today. So you all are more than welcome to still review those documents if you are interested in learning more about those approaches and maybe even understanding how your local and or state jurisdictions are working towards implementing them. Great, next slide. So in order to better understand how both strategies work together, we first need to understand something called the tier system. And so tiers are a set of criteria that jurisdictions are advised to use to assign each multi-drug resistant organism and their mechanisms of resistance. The point of these tiers is that they help guide us on what approaches to take when responding to these MDROs. And they also kind of guide us on whether we should be taking more of a response approach versus a prevention approach. I will say assigned tiers vary based on several factors. In CDC's guidance, they give a breakdown of what should be considered when you are assigning tiers within your jurisdiction. This includes data, outbreaks, patient networks, capacity that the jurisdiction has, the healthcare facility landscape, among many other things. And so that being said, CDC doesn't tell each jurisdiction what tiers to assign to what, because it's not going to be the same for everyone. The tiers are going to differ by jurisdiction on a state level, but even on a local level, and we'll discuss that here shortly. So we will talk about Arizona state tiers here soon, but before that, now that I've given a brief overview of how to understand the tier system, I want to talk a little bit about this figure that's shown on the screen. So hopefully this figure makes a little bit more sense now that we've touched on a few of these items, but the figure below shows how both strategies work together to reduce the overall burden of MDROs within healthcare and community settings. And it's based on the assigned tiers that I just talked about. So we see here that for tiers 1 through 3, a containment approach is mostly prioritized for these tiers. And that's because these tiers will include cases that are novel in our state or in your region. Also including mechanisms that could be novel in your region as well, all the way up to tier 3 organism, which includes those that are indicative of advanced spread in the area. So as we get to tier 4, so we follow the arrow and we get to tier 4 and we see that prevention is then the prioritized approach for those, because those are typically cases that are or organisms and mechanisms that are considered to be endemic. But what I really want to point out and what makes prevention just such a great strategy is that if we look closer, we see that prevention actually impacts all tiers. It's working in the background to impact all organisms, all mechanisms from tier 1 through tier 4. So just because it is the prioritized approach for tier 4 doesn't mean that prevention should only be used to target tier 4 organisms. Prevention is used to target all tiers, and it is non-specific for the most part. So we'll chat a little bit about what those activities could be and what they are for our current jurisdiction. Next slide. All right, so now that we understand the framework of our approaches to overall MDRO management, how both strategies work together, let's take a closer look at what our state is doing and the key components to both containment and prevention, starting with our assigned tiers, because like I said, we first need to understand tiers to understand how we have impacts or how each strategy impacts those MDROs. So these are our state's assigned tiers. As we can see in the table below, I'll go ahead and talk about each column and kind of why they are there, what they mean. So for tier 1, as I mentioned, that is based on the epidemiologic stage of having no cases. They're novel, they're organisms and resistant mechanisms that have never or very rarely been identified in the United States. So we don't know what those are, right, until they pop up. So we don't have anything listed there right now, but they are those novel organisms and mechanisms. Then we shift over to tier 2 and we get into the MDROs and mechanisms under the epi stage of limited to moderate spread. And as you can tell, all of the organisms and mechanisms fall under tier 2 for at least one region within our state. So we'll start from the top, but this includes pan not susceptible and pan resistant organisms. This also includes VRSA, but I do need to make the caveat that VRSA has its own CDC investigation manual. However, for consistency, we still wanted to add it and include it in our overall tiers in terms of the urgency of response to VRSA. Also CPCRE with IMP, VIM, and OXA48. So as Celine mentioned, she described earlier what carbapenemase producing organisms mean, the different mechanisms that we're seeing in Arizona. So carbapenemase producing CRE with the 3 mechanisms, either one of them, IMP, VIM, or OXA48 would be considered tier 2 for the entire state of Arizona. Now, after that, we can see listed here that we get into organisms and or organism and mechanism combinations that could be one or the other. And that's because it really truly depends on the region. So we get into those that could be tier 2 or tier 3, which would indicate advanced spread, or even tier 4, which includes those that are endemic. And again, that depends on the region, and we'll talk a little bit more about what that could mean. So starting with CRS, so CRS could be either tier 2 or tier 3. Carbapenemase producing Pseudomonas aeruginosa, that includes any and all mechanisms that we're seeing with carbapenemase producing Pseudomonas aeruginosa. That could be either tier 2 or tier 3 as well. Same thing with carbapenemase producing Acinetobacter baumannii. Regardless of the mechanisms that we're seeing at this time, it could either be tier 2 or tier 3. And then finally, we get to carbapenemase producing CRE. As you heard Celine mention, we are seeing a lot of NDM in our state. But prior to that, we saw a lot of KPC as well. And so depending on the region, the specific local jurisdiction in our state, CPCRE with NDM or CPCRE with KPC could be either tier 2, tier 3, or unfortunately even tier 4. I do want to note that, and I've kind of alluded to this already, but just to kind of chat about it a little bit, we're made up of several local jurisdictions, and we all have significant differences, or each local jurisdiction could have significant differences. Part of that could be in the data and the outbreaks that they see versus even those that they don't see. So we have jurisdictions that may see more commonly outbreaks in their region, but we have another jurisdiction that has maybe never seen an outbreak in their region. We also have differences in healthcare facilities that they have versus don't have. Some have many hospitals in their region, others may have none, honestly. I think we have one local jurisdiction that doesn't have a hospital located in it. And then also capacity for implementation of response versus prevention activities, among other factors. So what we truly wanted to do when we were working with our team of state EPIs, our overall team here at the state, we wanted to make sure that our Arizona statewide tiers captured those differences and considerations for our state, because it's going to impact how these organisms and mechanisms are being responded to, and or what approach we take to address them. All right, next slide, please. So now that we understand what Arizona's landscape is for tiers and what our statewide assigned tiers are, as I previously mentioned, in alignment with CDC's containment guidance, the response tiers really tell us how to address these cases, especially during case investigations. So here we see a breakdown of the CDC provided response elements based on each tier. And so I'll go into detail on what they each mean and why they would be for some tiers and maybe not others. I will say this is a summary of the response elements. In CDC's containment guidance, they go into a lot more detail on the specifics for each one. So again, if you're interested, highly recommend looking through that, especially if you are a healthcare facility within Arizona. So starting off with laboratory surveillance, that is conducted for tiers 1 through 3, and that is to allow us to ensure correct detection is happening and that reporting is happening for these MDROs. It should be happening regardless, even before we address or before we investigate a case. But we really just want to make sure that we are using that case investigation as a reminder and making sure that they have heightened surveillance now that we know that that facility has a case or that lab detected an MDRO. The next response element in that second row are infection control assessments, and those are conducted among healthcare facilities. They're also known as ICARs. I'm not sure if any of you are familiar with that terminology. It's infection control assessment response, and they are, when doing those assessments, you utilize a standardized CDC developed tool for ICARs. And the whole point of them is to assess infection prevention and control practices among impacted healthcare facilities. And so it's not regulatory. It's truly there to help encourage and help inform the healthcare facilities, the IPs at the healthcare facility, and help them address gaps that we might be seeing that maybe they didn't even think about prior to having a case at their facility or prior to an outbreak. And so this is our way of really stepping in and making sure that we can do what we can to help them assess those practices. And so these infection control assessments, they are conducted for tiers 1 through 2. Sometimes they are conducted for tier 3. Now, moving on to the next section, we have contact colonization screening. And so this is colonization screening that happens among maybe roommates of the index case or patients that shared a bathroom with the index case. Sometimes it even includes patients that may have been admitted into the same room as the previous index patient as soon as they were discharged. So they would also be considered close contacts. And so we do colonization screening among contacts to the index case for tiers 1 through 2, and again, sometimes for tier 3. I'll talk a little bit more about screening here soon, but I want to touch on the next one as well, the broader colonization screening. And so that is not just focusing on roommates now or close contacts, it's focusing on the entire unit. And or the facility impacted. So if there's a patient who gets admitted to a facility, maybe they weren't on any precautions, or maybe they were, but the facility continues to see additional cases. And so there is suspicion that there's transmission happening at that healthcare facility. We want to probably utilize a broader screening approach and then screen the entire unit that patient was on, maybe even especially if that patient had been there for months. Prior to their MDRO being detected. So we use both the close contact colonization screening and the broader colonization screening hand in hand. It just depends on what makes the most sense for the situation, the outbreak, the case investigation. And so for the most part, broader colonization screening is conducted for tier 1 and sometimes for tier 2 and tier 3. Colonization screening, it is facilitated and coordinated by public health. So the screening happens either through our state lab. Currently, our state lab conducts screening for CRS, or we go through our CDC regional lab located in Utah. And so currently we go through them for the other MDROs. It is free of charge to the facility, and I will just note that the sometimes for the screening under columns either tier 2 or tier 3, it depends on factors and considerations of the investigation. So I will say that's one of the great updates that CDC containment guidance recently had in their documents, in their most updated version from 2023, is they really expanded on scenarios, on different considerations to that may play a role in your decision on how you're going to address these cases. So they do a really great job of that. Again, highly recommend reviewing that as well, but that's essentially what we use because there is no one size fits all in terms of these cases. So we use that as a guide for what approach to take and or if we should be approaching using both. All right, the last one, environmental screening or sampling is sometimes recommended for tier 1. It's not typically recommended for the other tiers, so it's not a common activity. So I'm not going to touch too much on that. It's really just meant for those novel organisms. If in the case or in the event that we may find that helpful, we will conduct some sort of environmental sampling, but that is upon discussion with CDC and like guidance from CDC as well. And then finally, as I mentioned previously, tier 4, as you can see here, it doesn't have any response elements listed under tier 4. And the reason for that, as we saw in the figure from earlier, is because we really want to prioritize those prevention strategies for tier 4. You can, if you kind of picture in your mind the arrow going from tier 1 to tier 4, you can see that with tier 1, it's again, those novel organisms and mechanisms, which is why all of these response elements mostly say yes, except for the environmental sampling one. But then as we get closer to tier 4, less of the response elements say yes. And that's because as you work your way towards tier 4, you also want to be working your way to shifting your priorities to focus on prevention. So that is the whole purpose of both approaches working together. Next slide, please. Alrighty, now that we discussed our state's response elements, let's dive into the other approach. And honestly, it is my personal favorite, so I can talk for hours about this one, but I won't. Prevention strategy. So in alignment with CDC's prevention guidance, these are the 4 key prevention strategies for jurisdictions. It starts with conducting education, excuse me, improving infection prevention and control practices, detecting colonized individuals, and facilitating communication. So I'm going to start off from the top and just kind of talk about activities and projects that we're working on to address each of these strategies and to implement them. And then in the next few slides, I'm going to focus a little bit more on the facilitating communication piece, just to share some exciting updates and resources from that recently. So starting with conducting education, our Office of HAI launched an infection prevention training course series for local health department staff to teach basic IPC principles and ICAR elements. And the reason that we targeted our local health department staff is because we wanted to make sure we did more of a train the trainer approach, as in our state in Arizona, the local health departments are primarily the ones that work closely with the healthcare facility. They're the ones who work with them and provide guidance for case and outbreak investigations. They're the ones encouraged to lead ICARs as well. So that's why we used more of a train the trainer approach. And we got really great feedback, really great participation. So if any of you on the call participated in those from our local health departments, thank you again. And then moving on to the next strategy, we have improving IPC practices. And so this one goes hand in hand with conducting education, because they both kind of work towards the same goal of wanting to improve education and improve IPC practices among our state. But I'll highlight just a few other activities focused on this strategy. The first is we did launch an HAI newsletter, and that HAI newsletter goes out to our partners, including infection preventionists, healthcare facilities, and we use that newsletter to share information on the latest guidance, outbreaks, announcements, recent updates and reporting, and trainings that we really want to make sure that our healthcare facilities are aware about. So that has been a great success. We try to send it out every month. Aside from that, we also continue to collaborate with our partners to conduct ICARs and make sure that those ICARs are continuing to be conducted despite potential capacity issues, or even just a lack of knowledge. We do our best to ensure that we can support ICARs as much as possible. The third prevention strategy is detecting colonized individuals. And so similar to the screening approach for response, these are recurring facility or unit-wide colonization screenings that happen among high-risk facilities. And the purpose of this strategy is to help detect, as the name suggests, is to help detect colonized individuals before an outbreak starts. So in Arizona, we're using a phased approach, as this very much depends on which counties have high-risk facilities in their jurisdiction, and or if there is enough lab capacity to implement this. As you saw, we have a high number of MDROs, and so we also have a high number of healthcare facilities being impacted. So we want to make sure that if we are launching a prevention strategy like this, it makes sense for the settings that we are implementing it in, and that we have the capacity to be able to withstand it for a significant amount of time, to be able to see a difference in the strategy being implemented. So far, we have implemented this in one county, which has been very successful. Huge kudos to them, and looking forward to hopefully expanding this strategy to other counties as well. And so again, I kind of already alluded to this, but that being said, the other part of this strategy is that we are continuing to work with our regional and state lab to assess lab capacity for this testing as well. Finally, we have facilitating communication, and I'm actually going to go into detail on this strategy in the next few slides, but for a quick summary, we recently updated our Arizona Administrative Code, and we improved our Arizona Interfacility Notification Form, and we will jump into that now. So next slide, please. All right, starting off with our reporting rules, our Arizona Communicable Disease Reporting Rules recently underwent major changes earlier this year. As Celine mentioned as part of her data overview, they were published and officially implemented in June of 2025. For the sake of the focus of this presentation, I'll be touching on the updates among our targeted MDROs only, but there were several other changes, so if you are interested in reviewing those, they are posted on our website as well. Next slide, please. So previously, we'll start off with provider reporting requirements, but previously CRS was part of the emerging or exotic category for provider and laboratory reporting. Now, since the update, CRS is listed in the provider reporting requirements separately, and that's to make it clearer on how and when it should be reported, rather than assuming that everyone knows it should fall under emerging or exotic. So the reporting requirement is that all providers should submit a report within 1 working day through an electronic reporting system or by telephone after a case or suspect case is diagnosed, treated, or detected. Next slide. For laboratory reporting requirements, very similar, but first and foremost, we did update the nomenclature for CRE, so it is updated to the correct name, carbapenem-resistant enterobacterialis. And then next, similar to what I mentioned for the provider reporting updates, CRS, CRPA, and CRAB were all previously listed under emerging or exotic. And now they are each listed out separately. So again, that makes it clearer for labs to understand that these need to be reported. And we'll go into on the next slide how they should be reported. So we see a summary of what those requirements are for clear understanding among our partners. Here we see each icon depending on the MDRO. And so I'll just touch on three icons, I'm sorry. The first one being an exclamation point for Candida auris, which I mentioned is to submit a report within 1 working day. The next is a computer for CRAB, CRE, and CRPA, and that means that they should be submitting a report within 5 working days after obtaining a positive result. But the last piece that impacts all of these MDROs is that they should all have an isolate of the organism submitted or a specimen for each positive test result submitted to our state lab. And so that will lead us into our next slide, please. All right, so as you may have probably noticed, the reporting requirement is a 2-part approach. So not only should the cases be reported via ELR, as I mentioned, but they also need to have an isolate submitted to our state lab, as I just mentioned on the previous slide. And so our team noticed that sometimes these 2 requirements get overlooked. So we wanted to make sure that we had a resource to visually show that both of these aspects are part of the requirement for reporting. So we created these flowcharts. They're available on our website for those visual learners. We previously had one for CRE that we recently updated. And then we created flowcharts for CRAB and CRPA. So we're really excited about these. Share them as much as you can, share them widely, because we want to make sure everyone's aware of the correct reporting and isolate submission requirements. All right, next slide, please. Okay, and so just to wrap up on our communication, how we're facilitating communication in our prevention strategy, one of the ways that we recently did that as well is we wanted to make sure we strengthen communication between healthcare facilities. So if you didn't know, Arizona has a requirement of interfacility transfer notification for patients infected or colonized with an MDRO. And that requirement is outlined in Arizona's administrative code, and it's also outlined in the CMS long-term care appendix, and both are linked here as well. Next slide. CDC has their own general interfacility transfer form, but our team wanted to work with our Arizona STEP subcommittee to update an Arizona-specific form to make sure it really targeted the information that we felt our facilities needed. So after several feedback sessions, surveys, conversations, and collaboration with the Arizona STEP subcommittee, this form was updated in 2024, and it was distributed to our partners and also posted on our website. So we included updates to the infectious agents list based on our targeted MDROs. We expanded the patient and transfer information, contact information for the staff completing the form, and the most exciting, I think, update that we made was we made it an electronically fillable PDF, because obviously with the use of electronic medical records, we wanted to make sure this form was being uploaded into that, and it was easy to do that. So we've had really great feedback already regarding this form, and we take any chance we get to highlight it for those of you who aren't aware of it. You can start using it. Next slide, please. So that was a rundown of our containment and prevention strategy in our state. As Celine mentioned, we also wanted to provide some resources and relevant publications. So the top few bullet points are the resources that I mentioned during my portion of the presentation, and also from Celine's portion as well. In terms of the year-to-date stats, that's linked on here too. And then we included 2 recent publications. One is from New York City that is also noticing an increase in their NDM-CRE. It's an MMWR that they published. And so that was a really interesting read if you haven't read it already. And then CDC recently published a report on changes in CP-CRE from 2019 to 2023, which is also a great read. So we wanted to share those with you all as well. Next slide, please. All right, and without further ado, thank you so much for listening to us, and I hope you all found the information helpful. I will pass it on to Roshana. I'm not sure if we have time for questions.
Thank you, Juliana and Celine, for the great presentation with a lot of great information. We do have few more minutes. for questions. If anyone wants to ask questions, feel free to use the chat or raise hand function to ask questions.
We do have one question in the chat that came up during Celine's presentation I think would be great to discuss from Valerie that had to do with carbapenem-resistant Pseudomonas in the water supply. So it can show up in things like vents, eye drops. Do we have any insight in Arizona where we're seeing those or tips on where facilities should be looking for these organisms?
Not specifically. We did mention, I know in Celine's portion and also just in ours too with the environmental sampling, sometimes with these organisms, we do see them in water like Valerie mentioned, but we try our best not to be too specific on what to focus on. It's just a widely targeted organism in general among our healthcare facilities. So we don't have that information at this time, but it's a really great question.
Thank you.
Thank you, Juliana. I have a quick question. I saw one comment in the chat as well about the rise in NDM cases in Arizona. Do you know why we are seeing those increase in Arizona with a lot of NDM cases? Any idea whether it's due to the outbreak or any maybe due to the testing, increase in testing like that? Any solutions you provide will be helpful.
That is the million-dollar question that we receive every time. Or that's at least what we call it. But we don't know the exact reason for the increase that we're seeing in NDM. There's a lot of speculation, and we do have projects underway to try to understand it a little bit more. We've considered maybe changes in population, maybe even impacts from COVID-19 and PPE use and or IPC gaps that we saw during that time. I know CDC also recently published some information, I think a recent threats report on how there was an impact from COVID-19 on all MDROs. And then I know our team is also working with whole genome sequencing teams as well to understand the genomic relatedness between isolates and clusters, and hopefully that can give us more information. But unfortunately, we don't know the exact reason for the increase. I don't know if we ever will, but it is something that we are very interested in learning more about, which is why it's also our favorite question too. But that is one of the reasons that we did share the MMWR from New York, because they also touched on it. They're another jurisdiction in the United States that's experiencing a very high rise in NDM. So we felt like we could connect with them quite a bit because of that. And they also touched on how they also don't know the reason. And so it's just something that we're all working together to try to figure out, and hopefully one day we will. But that's a great question. Thanks, Roshana.
Thank you, Juliana. My last question will be about the interfacility communication tool you provided. How effectively the facilities are using that, and do you have any experience about how the facilities are utilizing that, and is there any gap in utilizing that in Arizona facilities?
We've heard overall very positive feedback with facilities using that. I will say that it's never perfect. So our local health departments, because again, we're not the ones doing the investigations ourselves, it's the local health departments. So a lot of the feedback we get is from them. And so sometimes we do hear that facilities either didn't use it or they'll just kind of put it part of the discharge paperwork, but not on top. So I think that's why we take any chance we get to really share the form itself to make sure that all facilities are aware of how to use it in the correct way, because we want that to be 100% reliable for them.